The Centers for Medicare and Medicaid Services established the Rural Health Transformation Program as a massive federal funding mechanism, injecting capital directly into state-level healthcare systems. The scale of this intervention is a proposed $1 billion allocation, distributed over a strict 5-year budget period. To see how that money actually hits the ground, we have to look at how a specific state handles the capital. We're going to examine the application submitted by the state of Colorado. The entity tasked with securing and managing this capital is the Colorado Department of Healthcare Policy and Financing, or HCPF. We're going to bypass the broad clinical goals of their proposal. Instead, we are focusing strictly on the financial and the mechanical architecture that HCPF built to manage the funds. Their model relies on 3 defining pillars: pushing money out through decentralized subawards, aggressively suppressing their own administrative overhead, and heavily overweighting investments in technology. This pie chart details how Colorado divided its $1 billion request across the 5 strategic goals mandated by CMS. The state allocated its largest portions to tech innovation, innovative care, and making rural America healthy, followed by workforce development and sustainable access. Colorado's proposal functions as a high-efficiency, low-drag capital distribution engine designed to fuel regional care networks. Managing a $1 billion federal grant requires significant overhead, and the federal government permits states to siphon a portion of the grant to run the program themselves. According to the Federal Notice of Funding Opportunity, that administrative cap is set firmly at 10% for direct and indirect costs. Colorado submitted a highly compressed administrative budget, coming in far below that federal allowance. The state is requesting an overhead allocation of exactly 2.98%. This bar chart translates those percentages into raw capital. The maximum federal ceiling is $100 million. Colorado asks for just $29.8 million. That creates a $70.2 million delta, money the state actively pushes out of its central bureaucracy, directly into the programmatic side of the ledger. That creates an immediate operational tension. HCPF still has to manage the distribution and compliance of $1 billion, but they have to do it with a fraction of the allowed funding. To solve this, Colorado built a highly restricted central management team, consisting of exactly 18 full-time equivalent positions over the 5-year period. Looking at the personnel salaries table from their budget narrative, we can see the functional composition of this team. The focus is heavily skewed toward contract management. Notice the reliance on procurement drafters and grant specialists rather than clinical directors or state care providers. HCPF deliberately avoids creating a massive new state bureaucracy. They opt instead to operate as a lean administrative switchboard to route capital outward. This outward routing relies entirely on subawards, and the federal government explicitly delegates the selection of those local partners down to the individual states. As this post-award FAQ document shows, CMS states clearly that they do not review request for proposal or award opportunities preemptively. Because of this delegation, Colorado acts primarily as a competitive clearinghouse, taking federal funds and distributing them via grants to regional care networks. Pushing $1 billion out to independent local clinics creates a massive compliance risk. The state has to ensure these downstream partners do not misspend federal dollars on unapproved capital projects. To maintain control, HCPCF enforces strict federal expenditure limits, specifically Category B and Category J payments, writing them directly into the subgrant contracts as non-negotiable guardrails. Take Initiative 1.5, the Whole Person Health Program. This budget table isolates a $6 million line item specifically for Category J payments.
Look closely at the justification text. Category J is capped tightly at 15% and restricted strictly to minor renovations. It explicitly forbids new construction or architectural design, shutting down potential capital bloat locally. We see similar mechanical controls applied to Initiative 5, which distributes many grants to rural hospitals. Here, the state uses Category B payments to dictate provider behavior. This budget table highlights the Category B maximum line item. Again, it is capped at 15%, and the contract stipulates these funds must be tied directly to expanding small community partnerships in technology and serving elderly populations. Because the state has outsourced the actual delivery of healthcare, These strict categorical caps serve as the primary mechanical guardrails preventing independent local grantees from deviating from the federal mandate. There is a significant existential threat baked into the CMS mandate. The $1 billion is not a guaranteed lump sum. Future capital distributions are entirely contingent on rigorous annual technical score recalculations conducted by CMS. The penalty for failing to provide verifiable progress data to the federal government is severe. CMS explicitly states they will recover funds and reduce point scores in future years. Colorado's defensive strategy against this threat is allocating massive amounts of capital to build the exact systems required to generate that compliance data. We can see this by isolating the two largest tranches in their proposed budget: Innovative Care at $230 million and Tech Innovation at $255.5 million. Combined, these categories represent nearly half of the entire $1 billion request, $485.5 million. The primary vehicle driving the Innovative Care tranche is a framework Colorado calls the Carpe Diem model. The budget line item for Carpe Diem shows the financial structure: 40 grantees receiving $1 million each over 5 years. The goal is to pilot rural value-based care frameworks, shifting away from fee-for-service models. Implementing value-based care requires intense, granular data tracking to prove clinical efficacy and cost savings to federal auditors. To capture that exact data, Colorado built a technological backstop under Initiative 10. This budget table excerpt highlights a $4 million procurement specifically for chronic access and prevention dashboards to monitor these rural networks. The heavy budget weighting toward IT dashboards and value-based care provides the precise telemetry Colorado needs to defend its out-year funding from federal clawbacks. Looking at the complete architecture of the Colorado model from top to bottom, the flow of capital maps clearly. Funding starts at the federal CMS level, flows down into the state HCPF node, and branches out into 10 distinct localized initiative pathways. The state node acts as a highly efficient clearinghouse, draining only 2.98% for its own overhead, allowing the vast majority of the volume to bypass state bureaucracy and reach the local level. The bulk of that capital is routed specifically into the tech innovation and innovative care arteries. By minimizing its central workforce and enforcing strict category caps on independent subgrants, Colorado maximizes the direct capital distribution to rural providers on the ground. The architecture requires a continuous feedback loop between capital distribution and impact tracking. The technology dashboards close the reporting loop, sending that localized performance data back up the chain to the federal level. The ultimate priority of the state administrators is engineering a system capable of surviving rigorous, multi-year funding verification audits. Colorado's plan operates as a high-efficiency, closed-loop engine. It pushes federal dollars out to local clinics, while simultaneously pulling back the exact compliance data required to keep the entire program alive.